Hello and a very warm welcome to all my friends. INI CET November 2021 exam is over. We are talking about community medicine discussions today. So the disclaimer is that these questions, whatever I'm going to discuss is purely based on the recall from the students. These questions are not at all are intended to have a replica of what questions came in the exam. We are just going to talk about that, discuss about the topics over here. So don't be bothered if the questions are here and there, or if the options are left and right, or this was there, this was not there. That's okay. We are going to talk about the topics so that I ensure that next time you get the same question, not the same question, the similar question from the same topic, at least you are very easily going to do it. So because there's always a trend of topic to be repeated in the exam, right? So without wasting much time, let us talk about the question number 1. External validity of the screening test is related to generalizability, objectivity, stability, or the repeatability. So please note that what is this question talking about? The external and validity. So what do you mean by a validity? What do you mean by accuracy? And what do you mean by precision? If I show you this dartboard, I have done that already in many of my lectures, in many of my sessions, in many of my discussion videos with you. So if I show you this dartboard, let us say there are 3 friends. We are talking about the validity, accuracy, precision. If the first person is going to hit the dartboard, this is a dartboard, right? You play with like this. So if the first person hits the dartboard like 0.1, 0.2 and 0.3, can you tell me how many times this person was valid? The first person was valid 2 out of 3 times. Let us say another friend comes. He is going to hit like this, like this, like this. So how many times this green person is valid? This green person is valid 3 times, all of the 3 times. How many times this green person is accurate? This person is accurate only 1 time. So please note that accuracy is related to the closeness to the true value. So this patient, this hitting this bullseye is what is accuracy. So one thing is for sure, that validity means getting the result within a desired range is what is validity. So validity means getting the results within a range. You're supposed to hit a dartboard. Did you hit or not? That is validity. What do you mean by accuracy? Accuracy means hitting the bullseye. That means getting the closeness to the true value or the actual value. Closeness to the true value or the actual value, that is called as accuracy. So what on earth is precision? Let us say this friend number 3 comes. He is hitting the board like this, like this, like this, like this. Whatever times he hits away from the board. But he's hitting pretty close to where he was earlier hitting. So this phenomena of getting the similar results, mind it, getting the similar results within a very small range again and again is known as precision. So precision, how many times this third person was valid? He was not at all valid. How many times he was not accurate? Of course, it's a nonsense because he was not valid. How can he be accurate? And how many times he was precise? He was precise all the times. So he was precise all the time. So what does this precision means? Precision means getting the same results again and again. So technically, precision means repeatability. Precision also means reproducibility. That is also what is precision. So this question is talking about validity, that is getting the desired results within a defined range. That is what is validity. Now validity can further be classified into 2 types. You can have internal validity or external validity. So try to understand what I'm saying. Internal validity of a research trial or a research study basically pertains to how robust the results are. The results are within the same study. So that means that What is the element of, is there any bias out there? What is the big sample size, or what was the methodology of conducting that study? So how robust is related to the method of that conducting that study, or was there any specific bias in that study? So this how truly the study can find out the cause and effect relationship, that is internal validity. What do you mean by external validity? External validity is a separate entity. It technically means that if the results of my study are this, can I say that I found out about the response of hypertension or to a particular drug in my city in Chandigarh in a particular group of patients? Can I talk about the same results to be applicable to all India, or is it the same results are applicable even to the northern part of Ladakh people? Or is it the same results would be applicable to people, tribal areas living in Andaman Nicobar or in Odisha or in Bihar, Chhattisgarh? Will it be applicable? Because probably the genotype in Punjab for hypertension is different from the genotype in northern Ladakhi people, which is different from people living in the tribal areas in Andaman Nicobar. So external validity technically means a generalizability of your study on a bigger population. So does the results correspond to the bigger value? That is what is external validity. So external validity, the technical definition is how well the outcome of the study can be expected to apply to other settings. In other words, what is refers to how generalizable the findings are. That is what directly this question was asking. External validity of a screening test is related to generalizability. We already did that in our custom modules, in our video modules in edition number 5. We talked about internal external validity and the effect of generalizability. So it's a repeat question from our lectures. Coming to the next MCQ, a new drug had been introduced into the market which was found to decrease mortality, but it does not cure. So people will be stopped from dying, but it won't cure them. What happens to the incidence and to the prevalence? So probably they are talking of a non-communicable disease. So let's take, for example, they're talking of a non-communicable disease. I'm just contemplating. Because they have not told anything, I cannot, for certain reasons, I cannot take that they're talking of cholera or meningitis or they're talking of pneumonia, because it does not cure, it doesn't make sense to those conditions. So we're talking of a disease which has mortality and their people could live with that disease. So probably they're talking of non-communicable disease. So we have had long discussions on these. In fact, this was the basis of my whole epidemiological lectures in epidemiology. We started with this. What do you mean by incidence and prevalence? Let us assume there is a jug and this whole box that you see, this is the universe. You already know that there are people who fall into this jug. Let us say this jug is made up of disease. So there will be people who are in this jug. The people who are in this jug, they are called as the prevalent cases. The new people who fall into this jug, these will be called as the incidence cases. There are only two outlets of this jug. Either the people can get cured and they join back the universe, or they unfortunately die, or there is death and they leave the universe. So there are three options for a person. Either that person is going to stay in the prevalent area, or that person will be cured, or that person will be death because of that disease. These are the only three options which can happen. So now coming back to this MCQ, if you understand this, so this disease, this new drug which is there, it stops people from dying but does not cure. So common sense, this death thing is stopped, but the cure thing, it does not cure also. So what is going to happen to the prevalence? Common sense, the prevalence is going to increase. So if it is a non-communicable disease, the prevalence would be increased, let us say, to this point. So if the cancer prevalence is increased, if the hypertension prevalence is increased, if the diabetic prevalence is increased, people stop from dying, but they are not cured, the prevalence increase. Does it increase the incidence cases? Answer is, please remember that incidence will increase in communicable diseases, whereas in non-communicable disease, the incidence will not change. So because this question is not talking of communicable, non-communicable, in general, they're talking of any disease. Generally, we talk about non-communicable disease. So in generally speaking, there will be increase in prevalence. there will be increase in prevalence. But if the question had said that there was a communicable disease, mind it, if the question talks about gonorrhea, if the question talks about syphilis, if the question talks about hepatitis B, in those cases, there will be technically increase in prevalence and there will be increase in incidence. But since this question did not talk about communicable disease, so this is wrong, C is wrong, D is wrong. The best answer to mark here is option number A. Let us move to the next question. Which of the following is not done in meta-analysis? What on earth is meta-analysis? Meta-analysis is it's a study design which is a part of the evidence-based medicine. It is a part of the evidence-based medicine. So under the evidence-based medicine, we have two studies that you need to do. We were talking about the systematic reviews, and we were talking about meta-analysis. Please remember that meta-analysis, it is a statistical approach to find out the final effect. So that is what do we mean by meta-analysis. What are the steps when you conduct meta-analysis? So you already know that we have discussed this much in detail, that what do you mean by evidence-based medicine. See, in evidence-based medicine, what we do, evidence-based medicine. So what do we actually do in evidence-based medicine? We take all the studies which are happening in the world. See, in previous lectures, some time back, we talked about launch of any iron folic acid supplementation under the Anemia Mukt Bharat scheme. We also talked about launch of these monoclonal antibodies for COVID-19 pandemic or epidemic, whatever you're facing right now. We also find the relevance of artemisinin-based combination therapy for treatment of malaria. So how on earth would we able to find out that what's the effect of these drugs? Let's talk about bedaquiline in tuberculosis or artesunate in malaria. So there is a study in South Africa, there's a study in Chile, there's a study in Kenya. So different studies will be there. So study 1, 2, 3, 4 across the globe. In this whole globe, different studies will be there. So what we can do is we can take all these studies and we find out their final effect of all these. So basically a study of the studies is what is called as evidence-based medicine. So it is a study of the studies. So study of the studies is evidence-based medicine. It could be systematic reviews or meta-analysis. So what are the steps? First is you take down all the studies. So the steps to these is first is identification of the studies. So you identify the studies. What do you mean by identify the studies? You do literature. That means the study, research studies, literature search. So you take down Index Medicus, or you take down Cochrane reviews, or you take down maybe PubMed or Medline or any of the literature journal libraries. So you identify what all research trials are of your interest. Then out of those, this is a very important topic, that you select some of the studies which are pertaining to your particular age group or your particular population or your particular interest or your particular dosage or whatever you're planning to do. And then you do the abstractation. This is the most important element. This is the most important element, that you need to find out what is the relevant information. You take down the relevant information out of those study designs, and then you do the analysis. Right? Am I right? So in this whole scenario of identification, selection of studies, abstractation, and analysis, there's no point of doing a randomization of the studies. That doesn't account for in evidence-based medicine trial. And that's what the question was. Please note that randomization is the best answer over here. Which of the following is not done in meta-analysis? You do abstractation, you do screening of the literature search, you do allocation of that particular study designs, but randomization is never done in meta-analysis because that's not a part of the meta-analysis. The four broad steps of meta-analysis you should remember: identification, selection, abstractation, and analysis. So the best answer to that question was randomization. Let's go to the next MCQ. Simple direct MCQ. Subunit recombinant vaccine of hepatitis B will contain which of the following antigens? I think this is a more of a microbiology question. Answer to this is hepatitis B surface antigen. So what on earth are subunit vaccines? So subunit vaccines do not contain the live part of the vaccines. So subunit vaccines are usually costly. Subunit vaccines are usually costly as only the antigenic properties of the virus or the bacteria are taken up. So to elicit the protective immune response, that is what is a subunit vaccine. So only the antigenic part of that microorganism is taken. So that's the reason it's costly, because there are so many parts of the microorganism and every part has to be tested and tried. So that is what is a subunit vaccine. Hepatitis B is a subunit vaccine, and it's a subunit viral vaccine derived from the hepatitis B surface antigen produced in the yeast cells, and HBs antigen is what is the best answer to this question. You would also like to remember that which are the live vaccines. Please note that there is a mnemonic called as boy likes crime types. B stands for BCG vaccine, which is a live vaccine. O stands for the oral polio vaccine. Y stands for the yellow fever vaccine. Likes means the live vaccines. And then you have the C stands for chicken pox. R stands for rubella. I stands for influenza. M stands for measles vaccine. E stands for Japanese encephalitis vaccine, and TYP would stand for a typhoid vaccine. So the BCG vaccine strain is the Danish 1331. OPV, the strain is the Sabin strain. Yellow fever is 17 Delta strain. Chickenpox is OKA strain. Rubella is RA27/3 strain. Influenza is, we have a live influenza virus and we also have the killed ones. So it's just a live nasal virus, vaccine. Measles vaccine is Edmonston, Zagreb. J is SA 1414-2. SA 1414-2 strain. Typhoid is oral typhi 21A. These are the strains of the live vaccine, so you would like to memorize these vaccines. Also, there could be sometimes questions pertaining to the ingredients or the constituents of Covaxin, which is a killed vaccine. I would like to reinforce this point that Covaxin is a killed vaccine. Covaxin is the first killed vaccine produced from India, Bharat Biotech, and the constituents of Covaxin is the strain is NIV 2020-770. You need to memorize this. Also should know that the Covaxin contains an adjuvant, that is aluminium hydroxide. You should also know that it contains some stabilizers in form of TLR 7/8 and 7/8 agonist, and these are the imidazoquinolone derivatives. So any person who has any allergic reactions to aluminium hydroxide or these imidazoquinolone derivatives or to any of the derivatives of constituents of the Covaxin will not be given Covaxin. So you have to memorize the strain of the vaccine, that is 2020-770. It has adjuvant, that is aluminium hydroxide, TLR, toll-like receptor 7/8 agonist. And it is the first vaccine, Covaxin, used in India. It was the vaccine drive was started on 16th of January 2021 in India. Talking about the Covishield vaccine. Covishield vaccine, it's a live viral vector vaccine. The live virus, the viral constituents, they are packed in a protein, and that protein is the L-histidine. So alongside with L-histidine, you have the emulsifier that is used as polysorbate 80. The Sputnik is also a viral vector vaccine. It is a modified replication defective adenovirus, whereas in a Covishield, they use the chimpanzee adenovirus, and in the Sputnik, they use the modified replication defective replication defective adenoviruses. So Sputnik vaccine will also have polysorbate 80. Covishield will also have polysorbate 80. Covaxin does not have polysorbate 80. You can just remember these few points about the vaccines. And now coming to the next MCQ. Arrange the following in maximum to the least causes of neonatal mortality, prematurity, birth injuries, congenital sepsis. So when you are talking of the neonatal mortality rate, so in neonatal mortality rate, if you look at the table over here, whatever I'm going to discuss is basically based on the annual report 2020, which was based on the 2017 estimates. So till 2017, 12 to 17 estimates, cause of neonatal mortality was taken. So it was published in year 2020 by the Ministry of Health and Family Welfare, Government of India. The same has been also updated in your Park textbook 26th edition, page number 651. So in this neonatal, when you're talking about the neonatal mortality rate, can you believe that whatever is the neonatal mortality rate in India? So out of this neonatal mortality rate, 50% of the neonates will have their deaths because of a big unfortunate event of prematurity or low birth weight. That means 50% of the children die within 1 month because they could not attain their proper birth weight. They were less than 2.5 kilograms. The next in line is birth asphyxia, and then you have neonatal pneumonias, and then you have other features. So first is 50% children will die because of low birth weight. Then you have the birth trauma, birth asphyxia, and then you have other communicable disease. More importantly, you have pneumonias, and then you have in fact the other communicable disease. So please note that low birth weight is one of the major important causes, low birth weight and prematurity. Low birth weight and prematurity is one of the major important causes of neonatal mortality in India. I would also like to emphasize that the infant mortality rate in India is 30 per 1,000 live births. The neonatal mortality rate in India is 23 per 1,000 live births. So these are some important numbers you would like to remember for your exam. So coming back to the story, if you look at this table now, so the most important cause over here is prematurity and low birth weight. Then in line you have the birth asphyxia, then you have the neonatal pneumonias, and then you have other communicable disease. Please note that diarrhea is 3.1, whereas neonatal pneumonia is 12 and diarrhea is 3.1. Can we say that pneumonias are 4 times common than diarrheas especially in the neonatal age group? Are we okay with this? So you can get a hold of it that diarrheal diseases are 4 times less common than neonatal pneumonia or respiratory illnesses in neonates. So if you understand this, what is the best answer over here? Direct question, direct answer. You would like to answer 1 as the most important cause. So that is cause number 1. Then you have birth injuries and birth asphyxia. So then you have 2. And then you have sepsis as slightly more common than the congenital anomalies, then 4, then 3. So I think you should be marking 1, 2, 4 and 3 as your best answer over here. I would like to have a disclaimer that many students also told that probably there was a question related to the verbal autopsy. Verbal autopsy report in year 2010 till 2013. So that was the question. So please note that whatever data is latest, the MCQ has to be based on that. So the verbal autopsy report was also from 2010 till 2017. So it was launched in year annual report 2020 by the Ministry of Health and Family Welfare. They cannot ask that what was the neonatal mortality in 2005. How can they ask that? You are currently going to be doctors, and this was a INI set level exam. So they just had that probably that factor to make you scare or make you feel that fear factor that they are asking you 2010 data. The verbal autopsy report was gathered, and there was a 1 million death study. So all the report was compiled and given as annual report 2020 by the Ministry of Health and Family Welfare in year 2020. And the question was probably based on this particular reporting only. Coming to the next MCQ, there is an increase in the incidence of non-communicable diseases over past few years. What is this type of trend? So there is something called as seasonal trend. Then there is secular trend, cyclical trend, or periodical trend. So what happens is that whenever we are talking of long-term fluctuations or short-term fluctuations, there could be periodic fluctuations, or there could be other short-term fluctuations. The short-term fluctuations could be like point source epidemics or multiple source epidemics. It could be point source or multiple sources, which is like propagated epidemics or propagated outbreaks, and then you can have slow epidemics or other things. So these are short-term fluctuations. The periodic fluctuations could be like they come again and in some periodicity. It could be related to the seasons. Like you have about malaria, about diarrhea, about road traffic accidents. These are seasonal fluctuations. And then there are some cyclic trends. So cyclic trends are supposed to come in cycle. For example, for rubella, there might be increase in number of cases every 3 to 5 years. For measles, there might be increase in number of cases every 5 to 7 years. Let us say about influenza. There is 7 to 10 year cyclic trend. It is usually said that the trend would keep on happening again and again and again and again. Then there are sometimes, so these are short-term fluctuations. Then there is periodic fluctuations. Then there is also another term that is called as a long-term fluctuations. The long-term fluctuations are called as secular trends. So what is happening is, let us say that there is we talk about obesity. It has been seen that over past few years, or in fact, we usually talk about them in decades, like over 20 years or 50 years. So over last few decades, the incidence or the prevalence of obesity has increased. So we medically, in epidemiological language, you would say that we have seen an rising secular trend of obesity, or we are seeing a declining secular trend of tetanus, or we are seeing a declining secular trend of cholera, or we are seeing a increasing or rising secular trend of cancer or diabetes or hypertension, whatever. So secular trend is something which is over long term. Short term is outbreaks, and periodic is something which may happen due to seasons, due to cycles, or due to anything. So based on this, if you understand this question, there is an increase in the incidence of the non-communicable disease over past few years. That's what the main the keyword of the MCQ was. So the best answer I would like to mark is a secular trend over here, because that is what resonates with this particular MCQ. Let's move on to the next MCQ. Which of the following is the best study design to demonstrate the relationship between cause and effect? So I think this question has been dealt so many times in your Marrow video modules, in my textbook. Everywhere I've tried to discuss this question much in detail, and it's the same question which is coming again and again. It has been repeated around 5 times in the past, like 3-4 years only. So you can say this is a 5-star MCQ. So which of the following is the best study designed to demonstrate the relationship between cause and effect? So at the lowest level, you already know that there are animal or laboratory studies, and then there are case reports, then there are case control studies, cohort studies, randomized trials, and then there is the meta-analysis, right? That is the hierarchy I have told you so many times. So at the lowest level, you have something called as case series, or you have case reports. Then you have the basic study, that is the cross-sectional study. Then you have the case control study. Then you have the cohort study. So it's the same table, same triangle. I'm drawing the upside down. Okay. So then you have the cohort studies. Then you have the randomized clinical trials. And then you have the evidence-based medicine, the systematic reviews. And then you have the meta-analysis, right? This is what you already know. So please note, just a quick walk through these study designs. These are what are descriptive studies, the case series or the case reports, the cross-sectional, the case control, and the cohort. These are clubbed under the analytical studies. They are clubbed under the analytical studies. All these studies together, the case reports, the case cross-sectional, the cohort, the case control, all these together, these are called as observational studies, observational study designs. The randomized control trials, these are what are the experimental study designs, and these two are evidence-based medicine. That is what you already know. The cross-section study, it will give you only the prevalence. Prevalence is calculated only in one study, that is called as cross-section study. Will you be able to remember this? Next is the case control studies. It gives you the odds ratio. The cohort studies, it gives you the incidence. It gives you the attributable risk, the population attributable risk, and the relative risk or the risk ratios. Please remember, incidence is given by only one study, that is cohort study. Prevalence is given by only one study, that is the cross-section study. The randomized clinical trial, they will tell you about the effect of a vaccine or effect of a drug or a risk factor. And then systematic reviews and meta-analysis, these are the final outcomes. So basically speaking, the descriptive studies will help you formulate a hypothesis. They will help you formulate a hypothesis. The analytical studies, these analytical studies, they are going to help you test a hypothesis. They are useful for testing of hypothesis. The descriptive studies, please note, are useful for formulation. The analytical are important for testing of the hypothesis, whereas the experimental and the evidence-based medicine, they are useful for validation of hypothesis. That yes, this is the hypothesis that is happening over here. So please note that the hypothesis could be measured at 3 levels: formulation, testing, and then validation. So which is the best level for saying causality? The best measure for ascertaining causality is meta-analysis. This is the best measure. I'm not saying that the case reports or the case series are bad studies, but they are just the introductory studies, and one of the best study to a certain causality is meta-analysis. That is what is being shown by this diagram over here also, that meta-analysis and clinical guidance practice, these are the filtered studies. They are the best studies for ascertaining causation and association and about the effect and cause. So now if you look at the MCQ, which of the following is the best study design to demonstrate the relationship between cause and effect? See, mind you, which of the following is the best study design? I told you that the best study design to ascertain the effect or anything is meta-analysis. So now meta-analysis is not there. So now the question is saying that the cause and the effect. So cause means any natural cause this question is talking. So you cannot answer a clinical trial would be a wrong answer over here, because you're not trying to assess the cause over here. So clinical trials are basically interventional studies. Interventional studies, they do not tell about the cause and the effect. They will tell you about the drug and their effect. So the cause and effect has to be, answer has to be from observational studies. So it either has to be option number D or B or A. Which of the following is the best answer? So out of these A, B and D, which is the best study design, I would like to mark my cohort study as the best answer over here. So the best answer would be a cohort study. They are going to, the best study design to demonstrate the relationship between the cause and the effect is a cohort study, because they are talking of the observation study design. They are not talking about the effect of the drug can best be measured by. So then your answer would be a clinical trial. So don't get confused by these words. It's a simple epidemiological question. So don't get weighed away by this triangle only that sir said that maybe clinical trial is better than a cohort study. So I'll mark that now. You have to look at the MCQ question also. So moving to the next similar MCQ, which of the following is not a part of the case control studies? So what do you want to answer over here? So just now we saw about things about the case control, the cohort studies. So options given to you were matching, follow-up, strength of association, or selection of subjects. So I would like you to understand that case control studies are something which are like cohort studies. They go hand in hand. So what actually happens over here is that if I just show you that, let us say that there are 50 people with some disease and there are 50 people without no disease. So now to these 50 people with disease, you ask them, do you have a yes risk factor or a no risk factor? So you actually are going from disease towards the risk factor. And people without disease, you ask them yes risk factor or no risk factor. So technically speaking, you know that risk factor will cause disease. That is common sense. So now in case control, you start people with disease and you go back in time. So this is what is a case control study. Okay. Let us take another example where you take people who are with some risk factor. So there are some 50 people with a risk factor and 50 people there is no risk factor. And then you follow up. Then you follow up them for people with yes disease or no disease, yes disease or no disease. So you already know that as risk factor will cause disease. That is common sense. So in a cohort study, and the previous one was a case control study. So in a cohort study, you start with what? You start people with the risk factor. So you take people with the risk factor and then you follow them. You go forward in time. You follow them. So once there is an element of follow-up, this will be called as a cohort study design. Please remember, there is no element of follow-up in a case control study design. So follow-ups is always for case control. Follow-up is always for cohort studies, and case controls are always retrospective studies. So if you have recalled my lectures, please note that case control studies will give you the odds ratio. These are the retrospective studies. The case control studies, they go from cause to effect or effect to cause. They go from effect to cause. And that's the reason they are called as retrospective studies. And they give you the odds ratio, which is nothing but the ratio of the logical cells to non-logical cells. They tell you about the association. So if you talk about matching, yes, we will match cases and controls. Matching is done to match the cases with controls. Why? To eliminate confounders. You remember known confounders? How do you treat known confounders? Answer is matching. So matching can be done. Strength of association is found out by the odds ratio. The selection of subjects technically has to be done. So the best answer over here is follow-up. Follow-up is a common sense answer. It is mostly, not mostly, it is always done for cohort studies. So it is not a part of the case control. So that is the best answer that will commensurate with the MCQ statement over here. So now let's talk about the next MCQ. According to WHO, World Health Organization, what are the components of HDI? HDI stands for the Human Development Index. So HDI stands for the Human Development Index. So this question has been a 5-star MCQ. It has been a 100-star MCQ all the time. It is one of the most favorite question of the examiners, and it usually comes in almost every entrance exam. So beta, we are talking about the health indicators. There are two broad health indicators which you need to remember for your exam. We have the PQLI and we have the HDI. We also have another one, that is HPI. We will talk about that later. So what is PQLI? PQLI stands for the Physical Quality of Life Index. Physical Quality of Life Index. The Physical Quality of Life Index, it has three broad indicators. It talks about the literacy rate, it talks about the infant mortality rate, and it talks about the life expectancy at age 1 year. So how did I remember age 1 year? You remember it is PQLI. LI stands for L1. I just remembered it that way. So there are three indicators: basic literacy rate, the infant mortality rate, and the life expectancy at 1 year. These are the indicators in the PQLI, Physical Quality of Life Index. Then you have something called as HDI. So let's take a new page and talk about the HDI. HDI stands for Human Development Index. It is a composite indicator. It is a geometric mean. It is a geometric mean of three dimensions or three indices, which is made up of 4 indicators. So there are 3 dimensions or the 3 indices, which are the geometric mean of these 3 indices, and these are basically the 4 indicators which are there, or these are the 3 dimensions. So if you look at the dimensions or the dimension index which we might calculate, so the dimensions, if you can just see it over here, it's talking about the first dimension is long and healthy life. The dimension 2 is the knowledge. Dimension 3 is the standard of living. So these dimensions will be having 4 indicators. The long and healthy life, so the long life, it has the dimension of life expectancy at birth. That is what is the indicator. Then the knowledge dimension, it has 2 indicators in it. The mean school years, and the expected school years. This is going to give you the knowledge or the education index. It will give you the education index. So this one will give you the life expectancy index. Then you have the knowledge giving you the education index, and then you have the income. Basically the dimension is standard of living. So you have the standard of living dimension, which is measured in the gross national income, GNI, gross national income per capita in US dollars. So that is the GNI per capita. This is going to give you the income index. It is going to give you the income index. So there are 3 indices, and it's a geometric mean of these 3 indices. So how do we calculate this HDI? It is the index of the life index. So life index raised to power 1 by 3, that is the cube root of life index, multiplied by the education index raised to power 1 by 3, that is the cube root of education index, multiplied by the income index, raised to power 1 by 3, that is the cube root of income index. So this will give you the HDI score. This is going to give you the HDI score. This is the geometric mean of all these indices has to happen. So if you talk about these indices, so there are 4 indices, 4 indicators: the life expectancy at birth, expected school years, mean school years, and the GNI per capita. That is going to give you the human development index. If you talk about the HDI for India, you can remember the numbers. The health, that is the life expectancy for India is 69.7. I would like you to remember, it is important for you to remember that the target for the life expectancy we wanted to achieve is more than 70 years. And in fact, as per the HDI report 2020, we are very close to that number. We already have attained 69.7. The education index is 12.2. and the GNI per capita is 6,681 rupees per capita. So the HDI for India is 0.645, and India is standing at a rank of 131 Human Development Index as per the United Nations Development Program UNDP report. So it is published every year. So that is what you need to remember about HDI. According to this question, what is the best answer over here? HDI will contain life expectancy at birth, literacy rate, and standard of living. So the best answer I would like to mark is option number A. B option is not correct because it is 1 year. IMR, literacy, and standard of living is not correct because they don't take into IMR. Life expectancy at birth, literacy, and infant mortality is not correct because IMR is not taken. So please note A option is the best option. Now in this page in this screen, I had also talked to you about the HPI. What is HPI? HPI is exactly opposite of the HDI. HDI was talking about the life expectancy at birth. It talks about the chances of not surviving by 40 years of age. The HDI was talking about education. It was talking about mean school years, the average school years. So HPI, that is the Human Poverty Index, Human Poverty index. The human poverty index will talk about the school dropout rates or the illiteracy or the not literacy index. And then the HDI will talk about the decent standard of living. This talks about how poor the people are in terms of no sanitation, no water supply, no sewage system in the houses, no toilets, or number of people without toilets, or open air defecation, things like this. This is what is a human poverty index. I would also like you to remember that either it is a human development index or it is a human poverty index. We calculate the index. The index for any of the things in HDI or HPI, it has to be calculated by the actual value of that particular. Let us talk about the life index. So life expectancy in the actual value for that country minus the minimum value for life expectancy divided by the maximum value for life expectancy or whatever index minus the minimum value. So this is the formula to calculate the index for human development index or the human poverty index. The actual minus minimum over the maximum value for the present in the globe minus the minimum value for present in the globe for any indicator. So let us say there are 200 countries. The minimum life expectancy for any country, let us say, is 30. So maximum for any country, let us say, is 85. So average value, let us say, for India is 70. So 70 minus the minimum, let us say 30, divided by maximum value, that was 80 minus 30. So this is how we are going to calculate the index for every indicator. So that is what is index calculation, and this is what you need to remember regarding HDI or the Human Development Index. So now let us come to the next MCQ, the solitary only MCQ from Biostats. Interpret the following graph. So you could see a graph over here, and then you had a normal, negative skew, positive skew, or a skewed negative positive, or normal positive negative, or skewed with outliers, positively skewed or negatively skewed. So you had this A, B and C curves. You wanted to find out which of the following. So what do you think is your best answer over here? Now beta, for you to understand what is the best answer over here, you should know what do you mean by a skew. What do you mean by a skew? You already know there is something called as a normal distribution. What is a normal distribution? Normal distribution is a normal distribution that is a bilaterally symmetrical curve. Bilaterally symmetrical curve where the mean, median, mode, they all will coincide. So sometimes you might have a not normal distribution. Let us say there is a distribution like this. Let us say a first curve is something like this. You have a curve like this. This is of course a not normal distribution. So now your outlier is somewhere here. This is your outlier. This is your outlier. That means this is the one which is like extreme values. It is the outlier which is the extreme values. So this extreme values is toward the right side. So it will be better called as a right skew. It will be called as a right skew. Let us say sometimes by chance you might get a skew like this. So this could be your skew. So now where is the outlier? The outlier or the extreme values is on the left side. So mind you, whenever you see the outlier on the left, always see the tail. Beta, you always have to see the tail. You see the tail. Never see this part, never see the mountain part. Don't ever see the mountain part. If you see the tail on the left side, it will be a left skew. If you see the tail on the right side, it will be a right skew. Please mind this. Right side tail is a right skew, left side tail is a left skew. So whenever the question will talk to you about the left skew or the right skew, please note that in the left skew or the right skew, the mean, median, mode will not coincide. So what will happen to the mean or the median? Which one will have the highest value? Highest value not in the terms of vertical, in terms of the horizontal. Like which is more toward the, let us say this is high, this is low. So which is more to the high values, the mean or the median or the mode? If you talk of the vertical, the mode will always have the highest value. If you talk of the vertical thing. So if you talk about the left skew or the right skew, you always write down in terms of the mean, median, mode. So the alphabetically. So what is the first alphabet which comes in the dictionary? Which is the first word which will come in the dictionary? MEAN or MEDIAN or MODE? Common sense, it is mean. So always write down mean, then median, then mode. For the right skew, I'll again write mean, then median, then mode. Now, whenever the question asks me, I just do write down mean, median, mode. In the left skew, everybody looks towards the left. In a right skew, they all look towards the right. That means what? In a left skew, beta, just remember, it's a small trick for you to remember. In a left skew, the mean is the lowest. The mean is the smallest. There's a greater and lesser sign, right? And the mode is the highest or the biggest or the maximum value in a left skew. And that you can see over here. The mode is the maximum value, whereas mean has the lowest value. Can you see this? In the right skew, the mean will have the highest value, maximum value, and the mode will have the minimum value. Minimum value will be for mode. So that is what is happening over here. So you can remember 2-3 points about the mean, median, mode, and left skew and the right skew in this manner. Done. Next is in the diagram that was given to you in the question, they had given you this type of a box. So what happens is, let us say that this is a data. Let us say the minimum value, and then you had the maximum point. Now in this data, if I cut my data into tiles, if I cut 1, 2 and 3. So if I cut 3 intercepts, of course I am going to have 1 tile, 2 tile, 3 tile and 4 tile. So it's a quartile. So now in this data, each tile will contain how much? Each tile is going to contain 25% of the values of the data. So now if I make this data as one box, the center tiles as one box, the box will contain how much? The box will contain 50% of the data. In the left tile, that is the lower tile, it will contain 25% and the upper tile will contain 25%. Are we correct? So these are called as Whisker and the box is called as the box. Please mind it. The quartile one, this is the intercept one, Q1, and then you have the Q2 and then you have the Q3. Please note that the difference between the lower quartile and the upper quartile. The lower Q1 and the Q3, the lower and the upper, the dimension of the box, please note, is called as the interquartile range. Interquartile range is not the difference between Q1 and Q2 or Q2, Q3. It is the difference between Q1 and Q3 or Q3 and Q1. Please note, I'm repeating it again. Do not commit the small mistake. Interquartile range is not the difference between Q1, Q2, Q2, Q3. It's the difference between Q3 and the Q1. It will tell you about the length of the box is given by the interquartile range. And then you have the whiskers. Whisker will constitute 25%. If you understand this, can you tell me if I give you a box and whisker? This is called as a box and whisker, right? This is called as a box and whisker plot. If I give you a box and whisker plot like this, let us say a box and whisker plot is like this. So what does this mean? This means that how many values are there in this whisker? 25. In the box, there is 50%. So can I say that 50 and 25, 75? 75% values are within this range and then only 25 are in this big range. So can I say that this data something looks like this? Can I say like this? Absolutely, this is a skew. If the box and whisker is something like this, so again, this is a skew. If the box and whisker is something like this, so that means this is a normal box and whisker, normal. So the data is kind of a normally distributed. Of course, this might be a little bit longer, but this is what is a normal distribution of the data. So we can say that each quartile will be having 25% and the median is going to lie absolutely in the center point of the data. So you'll have the mean, median, mode coincide. This is probably a normally distributed data. So you can have skews over here. So what is this skew? You can see that in a negative skew, In a negative skew, you can see that this is what a left skew. So the box and whisker would something look like this. Am I correct? So this skew is called as a left skew or a negative skew. And in case your box and whisker is something like this, so that means your data is something like this. So this skew is called as a right skew, also called as a positive skew. Okay, so now that is what the question was. They had just turned the box and whiskers in the vertical. So now you need to make your head turn angular to this, perpendicular to this, and then see, then you will understand many things. That what is this? This is a normal distributed data. And what is this? This is a skew. Can you see the skew over here? And over here you can see that this is again a skew. Can you beat this? So of course you can see the values over here. This is low value and this is high value. So what is this option number B? B is maximum data is there with the lower side with very few data on the right side, on the higher side. So this is a skew like this. Are you getting it? It is a right skew or a positive skew. Are you able to appreciate this? This is what is a positive skew. So I would say that B option is a positive skew or a right skew, whereas the C option is a left skew or a negative skew. C option is a left skew or a negative skew, and A option is what is a normal distribution curve or a normal skew, and like a normal curve, no skew. So that is what this whole question was saying. Examples displaying skewness. So you have a normally distributed data. You have a positive skew. Why positive skew? Because maximum values are on the lower side, but the outlier is on the right side, that is on the positive side. So it is called as a positive skew. And over here you have the outlier on the left side. This is a left skew or a negative skew. That is what is written here. So which is your best answer over here? You would like to mark option number 1 as option number C as your best answer, normal. Then you have a positive skew and then you have a negative skew. So with that, I think we have covered almost all your questions from INI CET November 2021 exam. I know that the community medicine questions were fairly easy, and we are very proud to say that 100% of the questions were from our Marrow application or from the Q Bank or from the videos or from the pearls. And we are very thankful to the whole team which is supporting your preparation and is able to give us the chance to help you in your journey of preparation. So with that all said and done, so please note that your revision is going to give you the best results in exam. Keep on revising, keep on studying hard. All the very best and take care. Bye-bye.